From ARUP Laboratories on the campus of the University of Utah, welcome to the LabMind podcast. I'm your host, Dr. Brian Jackson.
Today is Friday, the 2nd of May, 2025. We have an amazing treat for you today on LabMind. Our guest, Dr. David Fajgenbaum, is an associate professor of medicine at the University of Pennsylvania, where he directs the Center for Cytokine Storm Treatment and Laboratory. Now, if you spell that out, it's CSTL, which is pronounced Castle, and the significance of that will become apparent in a few minutes. Dr. Fajgenbaum is also author of the book Chasing My Cure, A Doctor's Race to Turn Hope into Action. His research has been profiled in many places, including the New York Times, and he just returned from Vancouver from the main TED Talk stage where he presented his story, so watch for that in the coming months. And we're very excited that he will be joining Dr. Bob Ogami on June 26th for a live webinar entitled Focus on a Rare Disease, Idiopathic Multicentric Castleman Disease, as a panelist along with Dr. Amit Dogan. Dr. Fajgenbaum received his undergraduate degree at Georgetown, where he was quarterback for their football team. He then went on to Oxford University in England for a master's degree in public health, an MD from the University of Pennsylvania, and an MBA from Penn's Wharton School of Business. Dr. David Fajgenbaum, welcome to LabMind.
Thanks so much for having me, Brian.
Let's start at the beginning of your story here. When you were a medical student at Penn, you had some pretty dramatic personal experiences. Could you just walk us through how that got started?
Yeah, I was a healthy third-year med student, and I had promised my mom that I would become a doctor in her memory. She passed away from cancer when I was in college, and I was well on my way achieving this dream of mine and this promise I'd made to my mom. And out of nowhere, I became critically ill. My liver, my kidneys, my bone marrow, my heart, my lungs, they all began to shut down. I felt more tired than I'd ever felt before. And I was a med student, so I felt pretty tired before that, but felt more tired than ever before. I had this horrible abdominal pain, noticed fluid around my ankles, enlarged lymph nodes in my neck. And I went from one of my medical school exams down the hall to the emergency room, and they hospitalized me, and then they admitted me to the ICU. And I spent almost 11 weeks in this horrible state of literally like actively dying. All of my organs were shutting down, but no diagnosis. We ran lab test after lab test. We couldn't figure out what it was. All the testing was done for maybe an autoimmune disease. Those were coming back negative or maybe unclear, looking for some sort of infectious etiology that could be driving this. Those all came back negative. Thought that maybe there was a malignancy here, maybe it was oncology related, but pretty much everything was coming back negative there. And so we were in this really big diagnostic quandary where we just didn't know what was going on. But eventually a lymph node biopsy was done, and an amazing pathologist had that lymph node sent to them. It was actually sent to the Mayo Clinic, and a pathologist at Mayo looked at the lymph node and said, I don't think this is lymphoma, which is what everyone was worried about. I actually think it's idiopathic multicentric Castleman disease.
So at what point along the way did that diagnosis come in? How many weeks after you started to get sick?
It was about 11 weeks into my illness, and it couldn't have been any longer because a couple days after the lymph node was cut out, but before we got the diagnosis back, my doctors told my family, this is it. He's not going to make it. And actually, a priest came in and read me my last rites because they were certain that that was it. So thankfully, the lymph node had already been taken out. Thankfully, there was some amazing pathologist reviewing my lymph node who came back with a diagnosis literally just in time to get me started on chemotherapy. And I got that chemotherapy maybe within hours of what would have been the end for me. And it turned things around. Of course, it wasn't the final treatment for me. I had a bunch of relapses after that, but it saved my life. That diagnosis was essential. It came in at the exact moment that it needed to.
I can only imagine that this is about the most stressful, physically overwhelming, emotionally and mentally overwhelming experience that I could possibly imagine. What was the impact to you personally of not having a diagnosis on top of everything that you were already going through?
It was so difficult. Literally to be going through the physical challenges that I was going through. I gained about 100 pounds of fluid because my liver and kidneys weren't working. I had a retinal hemorrhage that made me temporarily blind in my left eye. I was so sick and unwell that I really was only awake for a couple hours a day. But when you add all that physical stuff up, and then you think about the fact that there was this tremendous uncertainty, David, you're dying, but we don't know what's killing you. And add into that I was a third year med student. And so I sort of had this special faith in the system that, like, I'm at the hospital where I was taking care of patients, and I saw these doctors march in and they would treat people. And we didn't always treat everyone, but when we weren't able to treat them, it wasn't because we didn't know what they had. It was typically because whatever they had was so resistant to therapy that there was nothing that could be done. And this was this unusual position where it was like, how come no one can figure out what this is? I trusted this system. I was part of the system. These are my favorite professors, and they can't figure it out for me. I had a faculty member who I'd actually just done a surgery rotation with previously, who really became close friends, and they're still friends of mine today. And they were ready to open up my abdomen to see if they could find some tumor that was causing this. I mean, everyone wanted to come in and do something, but no matter how hard everyone wanted to try to find the solution, it seemed like no one could figure it out.
And this was in a world-class academic medical center. I mean, there are not places with higher caliber faculty than you're going to find in a place like Penn.
That's exactly right. The best doctors, in my opinion, the best hospital. And then I was also lucky because my dad's a physician and he was advocating for me and championing. And my sisters never left my side. It was like, if a diagnosis can't be made at Penn with an army of family and friends supporting you, this is a tricky diagnosis. And of course, I would go on to learn that it was a disease that didn't actually have a diagnostic criteria. And that's part of the challenge. Diagnosing a disease generally requires a checklist of what that disease is. Well, Castleman's was one of the few diseases left over all these years where there actually wasn't even a checklist. You basically needed to get lucky and have a lymph node get taken out because someone thought you had lymphoma, and a pathologist to look at it and say, this doesn't look like lymphoma. I think it looks like that thing called Castleman's I read about in a textbook, or I saw, when I was in residency, and then say, I think it's Castleman disease. But there was no, okay, well, if you think it's Castleman's, this is what you need to see, or these are the symptoms. None of that. And so, of course, as I dove into this battle against Castleman's, that was one of the first things we did, was to establish the first ever diagnostic criteria for Castleman's back in 2017. But part of diagnosing a complicated disease is you got to know what you're diagnosing. You got to define it first. And it just hadn't been defined yet.
In essence, you're saying that even though you finally got a label, you got this name Castleman attached to your situation, that it actually wasn't a complete diagnosis because there were all these other parts of understanding the disease that weren't even there yet.
That's exactly right. So the biggest one to start was just that the term Castleman disease actually describes, I believe, about 9 different diseases that are all treated very differently. And so first, if you get the diagnosis of Castleman's, well, what subtype of Castleman's do you have? Well, back then it was unicentric or multicentric. Now, like I said, there's 9 subtypes that really guide therapeutics. And so the lack of resolution and specificity on, well, what do you actually have within this umbrella term Castleman's didn't exist. And then to your point, there were no FDA approved treatments for any of those subtypes, none of them. So, okay, yeah, you've got a term for an umbrella condition where it's not clear which of those subtypes you might have. At the time, the subtypes didn't exist, and there's no FDA approved therapies. And so I remember for me, it was terrifying to not have a diagnosis. It actually might have been a little bit more terrifying once we got the diagnosis. I mean, I think it was good to have it, but it wasn't that much more reassuring to figure out that it was Castleman disease because there were no FDA approved therapies. And so it was like, well, let's see what we can do. And also, it was such an eye opener on the challenges of rare disease research. So I was diagnosed in Raleigh, North Carolina, because I had been medevac down from Penn with no diagnosis. My family's from North Carolina. I was dying. It was like, let's get him closer to home so when he dies, we can have the funeral in Raleigh more easily. Got medevac down to Raleigh, and that's where that biopsy was done. And the diagnosis came back while I was in Raleigh. They transferred me to Duke. At Duke, they basically told me that the only options that we had were chemotherapy. So I got chemo. But what we didn't realize is that just down the street at UNC, there was a randomized controlled trial going on of siltuximab. The only drug to ever undergo a randomized controlled trial for Castleman disease was literally going on 5 miles down the road from Duke at UNC, and no one knew. That just tells you the challenges of rare diseases. The best resource for medicine, in my opinion, is something called UpToDate. For every disease, it's like the Bible for how you treat that disease.
Very widely used.
It's widely used. Every doctor's like, I don't know what to do. I'm going to go to UpToDate. UpToDate said that there were 4 patients ever of my subtype of Castleman disease. 4 patients ever. And So we thought, we're like, man, I'm the fifth patient ever of this subtype of Castleman's. And then we found out that there were 79 patients with my subtype enrolled into that clinical trial down the road at UNC. There were other sites also in the US, but like, wait a minute, the math's not adding up. I'm the fifth patient ever, but there's 79 people in this trial. There was so much that wasn't known. And now, as you look back on it, you just realize, wow, we've got a long way to go for a lot of these rare diseases.
So to close the loop on the up-to-date topic, is it fixed now?
Well, you'll love this. I put this document together for like what the new pages should look like. And you may not even believe this because it just sounds too crazy. And I even had an email drafted to the editor. And in 2017, no, 2016, 2017, I got an email from Up to Date before I could send it to them asking me to be the author for the Up to Date page.
That's beautiful.
I was like, wait, hold on. What? I really hadn't sent the email yet.
Do you know how they found out about you?
Yeah, we had published a bunch of papers. Now we've published 100 papers on Castleman's in the last decade, but at that stage we'd published, 15 or 20. And so I guess the update editors were seeing these papers coming out, and that's why they asked me to do it. So now I'm the author. I never had to send that horrible email. You're not up to date with your up to date page, but I'm the author and really pleased with the up to date page, and they're actually amazing to work with.
So I want to go back to the event that got you your initial diagnosis, which was the lymph node biopsy. And obviously, I'm a little biased here as a pathologist. We want to see things under the microscope. But at the point that that occurred, you had, I'm guessing, hundreds of different tests, blood tests, radiology tests. Hadn't you had some multiple different biopsies of different organs at that point?
That's right.
Why did it take so long to get the lymph node? And what was the impetus for getting that lymph node sent to the lab?
Yeah, it's such a great question. I think that Castleman's is one of these rare conditions where, in my subtype idiopathic multicentric, it is so explosive that I went from totally healthy to so sick within really just a matter of about 14 days in the ICU from like onset of symptoms. And I was progressing and getting so sick so quickly that that window of time to like do a lymph node biopsy when you could even palpate them, I gained so much fluid so quickly, you almost couldn't even feel the lymph nodes in my neck because, like I mentioned, I gained about 100 pounds of fluid. And so there was a window early on where I think that, okay, lymphadenopathy, it was shown on the CT scan, he's getting sick, let's get him to the OR now. But I think the initial thought was he's getting sick so quickly, like this is probably something infectious. Maybe there's some virus here. And then once we got through all the infectious tests, which, take time, they take days to get back. Now it's okay, well, maybe this is not autoimmune disease. Let's do all that. And then by the time we got through all the infectious stuff and all the autoimmune disease, now it's like, oh gosh, maybe we should get some lymph node tissue. I was in the ICU, and a lot of times ICU docs don't want to take their patients down to the OR because they're worried, are they going to make it through? And so it's this really challenging thing where we needed the tissue, we needed the biopsy, but everyone was so worried that that would tip me over the edge and that I wouldn't make it through surgery that it ended up being delayed weeks and weeks. And I do wish that it was done earlier.
Have you ever talked to any of your original doctors from your first hospital stay about this? And do you have any sense of what they think about finding out about what they basically missed?
I've spoken to them a number of times, and honestly, my main feeling is just gratitude. They kept me alive against a disease we didn't know what it was. And yes, the biopsy could have been done earlier, but my overwhelming sense is just gratitude. They were looking for everything. They were focused on keeping me alive, and they did. They succeeded at keeping me alive long enough to get that tissue back. So there's no feelings of like, I wish you had done this or I wish you had done that. It's just pure gratitude for keeping me alive. And I think maybe the main thing is let's learn from it for the next patient. And actually, I share about this patient in my book, a patient named Gary. He has the same subtype of Castleman's as me. And within 2 days of him showing up at Penn, he had the lymph node biopsy done. He had the diagnosis. I got a phone call from pathology being like, hey, there's a patient on Silverstein 12, go visit. So I go up to visit him, and I walk down the hall. I get to the room. I look in the room. I see this patient who looks just like me. He's sick like me, fluid everywhere, IVs everywhere. And then I look and I see this angle from the window, and I realize he's in the exact same hospital room that I was in, I guess, about 6 or 7 years earlier. So same diagnosis, same symptoms. They made the diagnosis right away, and they happened to put him in the same ICU room.
So this is a great example of what the psychologists called recency bias, and they usually use that in a pejorative sense, that the doctors will tend to reapply a diagnosis that they've seen recently on new patients where it may or may not apply. But in this case, this was a good thing. Because of your experience, they were able to make the diagnosis much, much faster on the subsequent friend of yours.
That's the hope. I think that part of it is the recency bias, the experience, and then part of it is that I basically recruited all of the hematologists, oncologists, all the pathologists at Penn to be Castleman's doctors. So they've all helped with papers and done research. And so I think it's a combination of yeah, recency bias and also lots of education and engagement.
Now, the listeners won't be able to see this because we just have the audio on this podcast. But as we're talking to each other over Zoom, I'm seeing on the windows behind you all these really complicated diagrams of molecular pathways, particularly involving the immune system, different cytokines and things diagrammed behind you. Now, thinking back to medical school, I recall the two most intimidating tasks as being trying to understand anything about the immune system and trying to understand anything about the coagulation system. Immunity is incredibly complicated. You know this much better than I do. Do you think that complexity creates a particular challenge for a disease like Castleman's versus, say, I don't know, a broken hip where it's pretty obvious what the mechanics are that are going on?
Yeah, absolutely. The immune system is so complex and it's for me, it's awe-inspiring. The way that you can have this coordinated system that's disseminated all over the body and able to have these home bases of lymph nodes where you can go back to communicate and then go back out. It's mind-boggling and beautiful and amazing. And of course, Castleman's is an example where it's gone wrong, where instead of being this coordinated system that knows when to turn off, when to turn on, when to attack, when to go into surveillance mode, and Castleman's, for whatever reason, the alarm seems to be going off and the immune system is just on fire and is in attack mode. So I have a very profound respect for it because I've been on the receiving end of its attack. I'm also on the end of studying it and have learned so much. And I think that the complication of the immune system is frustrating and challenging. I think one of the things that I find exciting about studying the immune system in a treatment context is that though there are so many complicated pathways and so many different cell types and immune related genes that are involved, you could almost consider it like consolidation or at least some level of grouping of many of these pathways that are thankfully targetable with drugs. So even though rheumatoid arthritis looks very different from idiopathic multicentric calcium disease, which looks very different from maybe the most severe cases of COVID, blocking just one of hundreds of cytokines, interleukin 6, can actually result in resolution of all three of those conditions. And though atopic dermatitis looks very different from hemophagocytic lymphohistiocytosis or HLH, JAK inhibition can be helpful in both of them. And so the idea that they can look very different, the immune system can manifest its impact in different ways. Many of these shared mechanisms are really exciting because you use the same drug to knock out multiple of these diseases, which of course is why I'm alive, as I'm sure we'll talk about. It's this idea of drug repurposing that though you might make a drug for atopic dermatitis or for Castleman's or COVID or whatever it might be that you made it for, because of this redundancy in the immune system, you can actually apply a lot of these drugs in different ways and you can treat diseases that look totally different, but they actually share the same underlying mechanism.
The way that we tend to use the word diagnosis, I think, is a really oversimplified mental model and is far different from what I think you're describing here. The traditional term diagnosis, I think people think of that as sort of step one. We run some tests, we figure out which bucket you're in or which label to put on you. And then from there on out, that's when the interesting journey starts because then we do your therapy and everything from there on out focuses on therapy. What I think I hear you describing is something a lot more interesting and more interrelated because you're talking about the diagnostic stuff and the therapy stuff as being much more interlaced.
Yes.
How do you think about the diagnostic process relative to the therapy process?
Yeah, great question. My mental framework is that you need to get a diagnosis so that you know the realm of possibilities of the symptoms that patient can expect, the prognosis for that patient, and the potential treatments. Gives you a framework to start with. And then once you have that diagnosis, in my opinion, the way I describe it is that now you immediately turn into the world of looking for predictive biomarkers. So there's diagnostic biomarkers, like do you have the group of things, but now you need to get in the world of predictive biomarkers. And so that's where in a Castleman's patient, we think you have Castleman's. All right, let's go measure your soluble 2 receptor level, your VEGF level, your IL-6 levels. let's look at your CRP and your platelet count. And if you give me those 5 laboratory tests based on results that we published in the journal Blood Advances and also in Nature Communications, and actually another one in British Journal of Hematology, I can start to tell you between those 3 studies, what are the drugs that are going to work for you with pretty good confidence. And the reason that's important is that for a disease as severe and aggressive as Castleman's, where, like I mentioned, I would have died within 12 weeks of diagnosis. I got the diagnosis at 11, so thankfully I survived. But where the timing really matters, and it wasn't 11 weeks in the hospital, it was 11 weeks from start of symptoms. So you only have sometimes days or even weeks to get it right in the hospital, to both get the diagnosis, but now get to what's the right treatment. So these diagnostic biomarkers become very important very quickly. You might have a day or two of wiggle room between whether you get the test and you can give the right drug. And if you give the right drug, you save their life. Give them the wrong drug, they die. These predictive biomarkers can help you to predict what's going to work. They're biomarkers and they're driven really by mechanisms. And so when we see that there's high levels of vascular endothelial growth factor and SOL2 receptor, that's getting us to think about this being really T cell activation mediated. And, maybe you're going to want to direct therapy in that direction more. Of course, we also look at very traditional things like creatinine and organ function. That actually drives us towards using chemotherapy versus not using chemotherapy. But yes, I think that in medicine, you've got to get the overarching umbrella diagnosis, and then you've got to immediately start looking for what are your lab tests. And in some cases, they're NGS related tests, in some cancers. In other cases, they're simple things like CRP or ESR. But I think that is really where you arm yourself to really help the patient.
Now, of all of these markers that you've mentioned over the last couple minutes, were all of those tested during your original hospital stay?
Oh, no. Only one of them, only IL-6 was tested back then. It turns out of all of them, that's probably maybe the least predictive of the biomarkers. We've made a lot of progress these last 10 years.
So knowing what to test for is part of the story too. But in order to do that, obviously, you need to understand enough about the disease.
You're right, Brian. And I mean, actually, it was funny as a med student, I had this sense that we knew all of the things that you could test for. And it was just a matter of like, okay, do I do this one or do that one? But yeah, going through this experience, I've realized that there's a lot of things that we could test for that would be informative, but the medical community hasn't figured them out yet. There's a lot of, we call it the ignorome, which is basically the things we don't know about medicine. And I think that it's important to recognize what we don't know, because in med school, you're taught what we do know. And so I used to take multiple choice tests where I'm like, is it A, B, C, or D? There was never an answer. The world doesn't know, right? Like they never asked us a question where that could be an answer. It was always like something where there's an answer. So you learn the things that have answers, and you're sort of never told about all the things we don't have answers on. I think we got to like look at it, the dark matter of medicine or the ignorome. And I think it's important once you can realize that there's all this stuff that you don't know, that then gets really exciting from a research perspective. Then it's like, okay, where can I dig into the ignorome to make us less ignorant?
I have never heard that term before, but we need to start using that term more. That's a powerful concept.
And I think there's some real humility that comes with recognizing that there is the ignorome. And it's not that anyone individually is ignorant, it's that the world is ignorant to these concepts. And if we can all appreciate the ignorome and start trying to scrape information, I think that's good for all of us.
There was a quote in your book that really jumped out at me. Quote, "You can only see what you look for." What did you mean by that?
Yeah, Brian, you nailed exactly this idea of the ignorance and the lab testing part, because this was what was so surprising for me. I even had this idea that like you run tests to figure out what the diagnosis is. Like there was a test to figure out what did someone have, but as you know, there's no test to figure out what someone has. You do a test of a lymph node for Castleman's, you do a test of the blood for this. There's no comprehensive way to get to answers. And I think that my takeaway from this isn't that medicine has not been moving fast enough or that medicine is to blame. My big takeaway is, wow, we should be so proud of what pathology and laboratory medicine has advanced, because every one of these insights is on the shoulders, as you know, of entire careers that people spend to get every one of these things to move forward. So it's pretty amazing what we've done, but I think it's important for us to also recognize that there's still a lot of work to be done.
So while we're talking about laboratory tests, I also want to bring out a little anecdote from your book that I think would probably not get picked up by a lot of your readers, but is definitely something that would get picked up by laboratory professionals. You mentioned that C-reactive protein was one of the markers that was very helpful in tracking your course. But you also talk about an incident along the way where an individual C-reactive protein result became misleading.
Hmm.
Tell us what happened there.
Yes. And so this is an example where at the University of Pennsylvania, we use milligrams per liter, and at UNC, it's milligrams per deciliter to measure C-reactive protein. And so we were worried that I was having a relapse because my symptoms were coming back. And you should always pay attention to your symptoms and what the patient's saying. I was feeling very unwell. We did the test and we thought the CRP was just a little elevated because it was just barely over the upper limits of normal. Well, we had the wrong unit, so it was off by 10x. So it was actually 10x above the upper limits of normal. So this is where units really matter. And it wasn't just like me, this like med student with calcium was looking at it. My doctor looked at it and was like, well, it's just like barely over. But like it wasn't barely over, it was way over, and so I think this is just an important lesson. It also has made me into, like, the most paranoid patient ever. Don't trust any result or any unit, always double checking and triple checking, but there are examples like this where, like, that led me to then go another 2 weeks before I did blood work again, and it was, like, sky high, I was sick as could be, and for those 2 weeks, I was talking myself out of it, well, the blood work didn't look that bad. Yeah, this is just an example for how complicated this stuff is.
So part of this, I suspect, I can't be completely certain, but part of this is very much the fault of the clinical laboratory communities. If you look at the history of C-reactive protein, as you're probably aware, the original marker was used for general inflammation for infections and rheumatologic things. But then someone figured out that you could also use this as a marker for heart disease. And if you had even very slight elevations in C-reactive protein, that could be predictive for heart disease. But because you're looking at different scales here, someone had the quote unquote brilliant idea that let's call this a different test. We'll call it high sensitivity CRP and we'll put different units on it. So I suspect that that was the root cause of why you got a different set of units, and it probably has to do with the fact that both sets of units are in common use, but for different applications, but it's a complete mess.
I think you're right, Brian. The only thing I'll add is that I'm just remembering the values. It was a CRP of 26, which if you use milligrams per liter where the upper limit is 10, then 26 is just 2.5 times the upper limit. And so it's like, well, it's up. You're certainly not having the explosive flares that you had in the past. Well, it was off by a power of 10. It was actually 260. So it was 25 times the upper limits of normal. It is like exploding.
Right, and the other thing this points out is the way laboratory results are communicated is to provide typically a number with a reference interval with either an H or an L or a C, depending on whether it's inside the reference interval or not. But that's a very categorical way of looking at results. And what it doesn't communicate is scale. So if you're slightly over the upper limit versus massively 10 times over the upper limit, it doesn't really show up differently because we're just presenting this as like numbers in a list.
Yep.
I've long thought that we needed to communicate laboratory results graphically, and the tools just aren't in common use to do that routinely yet. But this is a dramatic example. So, did that put you at risk for delayed therapy?
Oh, absolutely. Yeah, I think it was 2 weeks of me feeling really bad, and basically my doctor and I sort of being under the impression, well, it can't be that bad. You've never had a relapse where you've only had 26 CRP. And for listeners, I don't know how often you guys hear CRPs. Like a CRP over 100 milligrams per liter is very high. I study hyperinflammatory diseases, and I've only seen a couple people that have ever had CRPs higher than I've had, as inflamed as you can humanly get before you're not around anymore.
Okay, I want to pivot a little bit here. Let's just say you're not a typical patient. I don't think you're typical in any way. Your disease is obviously a unicorn, and your personal attributes make you, in many ways, a unicorn. But I want to try and connect some of your experience of other patients trying to navigate their diagnostic journeys. And there was an anecdote fairly early in your care where you were being cared for by an oncologist who I believe you had a really good relationship with. But this oncologist apparently chastised you for telling him what to do. Do you remember that incident? And could you talk about the interaction there of you trying to be an active participating patient and being slapped down a little bit?
Yeah, absolutely. This is actually was my mom's oncologist. He took care of her while she was battling brain cancer, and she passed while I was in college. I admired him so much. I actually would spend my summers rotating and just sort of shadowing him, spending time with him. I admired him so much. He took such great care of my mom. And then all of a sudden, here he was taking care of me. And like you said, I was 10 weeks into my diagnostic challenges. I would wake up for a couple hours a day. I was pretty confused, but during those couple hours that I wake up, I would ask questions like, what's going on here? Have we done this test or that test? And I'm sure that a lot of them didn't make sense. But sometimes I think they kind of made some sense, especially as my family has told me them subsequently. And there was very much this paternalistic, you be the patient, I'm the doctor. And I remember my brain wasn't firing too well, but I do remember thinking to myself, I'm like, I would love to be the patient. Just diagnose me. Like, I don't want to be the doctor. I don't want to be thinking about this. You haven't figured the diagnosis out. Please help me to be the patient. But until then, like until you have the diagnosis, I'm gonna try. We're all gonna try because none of us have the answer. So yes, I think that was particularly frustrating back then, and I think it is frustrating when I hear about doctors that do take this very paternalistic approach. And there's a thin line, right? I mean, there's the other side of the coin is that sometimes patients are taking their care into their own hands, making decisions that don't make sense, shopping for doctors until they find a doctor to give them the diagnosis or the drug that they want. And that's not good, and that's not appropriate either. But I think there's somewhere in the middle where the patient has agency and they can ask questions. They feel empowered to ask questions, and doctors feel confident enough in their own shoes to be able to handle those questions.
Don't you think there's been a generational shift over the years, over the decades, I should say, from this paternalistic model to where patients have far more access to information than they used to? I mean, in the 1950s, you're not going to see patients getting much sense out of going to a medical library. But today, Dr. Google,
And we've adapted to Dr. Google. What we're about to have to adapt to is not Dr. Google, but Dr. ChatGPT.
yeah,
And that's a whole nother level because Dr. Google can give you articles to read. ChatGPT can give you answers to your specific questions. And I think it's going to be even a whole nother set of adjustments that we're going to have to make in medicine.
particularly in the rare disease space, I think it's pretty common for patients to actually develop really high levels of understanding because they're doing these deep dives into their disease. And I think it's not uncommon for patients to know things that their doctors don't know.
Absolutely. And I think that the best doctors are comfortable with that and comfortable with saying, A, you've done the research, and B, you have the disease. So, like, you can feel the manifestations, and C, this is rare enough to where I just don't have the experience. I think that that sort of humility, I think, is really important. And when all those things line up, I find that, yeah, care for patients can just be incredible.
So, for our last few minutes, I want to get your thoughts on biomedical research. You're a full time biomedical researcher, you're a card carrying academic at a major research institution. The ideal of academic medical centers has always been this promise that we have all of these activities under the same roof. We have clinical care going on, we have academics going on, and it's mutually beneficial. And yet, are those two activities really informing each other effectively? So I'd like to go back to a comment you made in your book when you got to Oxford, and you said that was your first exposure to the world of biomedical research, and you found certain aspects of that disappointing. Could you elaborate on that?
Sure. Yeah, the thing that was most disappointing was collaboration, even within fields. I mean, certainly no collaboration across fields, within fields. And I studied specifically, I was focused on cancer prevention and cardiovascular disease prevention, and the idea that the same interventions, so diet, physical activity, and smoking cessation, could actually improve outcomes across cancers, but also across heart disease. And this was back in the early 2000s. And so some of this was not totally fully understood, but and my ingoing hypothesis was that if the same intervention can have an impact across multiple conditions, that certainly we must be measuring these outcomes. But actually, what I learned is that the cancer researchers were looking at how smoking cessation and diet and physical activity could improve cancer outcomes, and they weren't even measuring cardiovascular disease outcomes, and vice versa. And the same studies were being done by different groups, and they had to be repeated because they weren't measuring the outcomes for the other disease. And for me, that was like mind blowing. It's like, wait a minute, we're talking about the same interventions, sometimes at the same institution, but by different people. And because they were different people, they weren't talking to one another. They weren't sharing results. Things were being repeated that this drug didn't work in this group and we're going to do it over again in that group. This vitamin, like, and so for me, that was very frustrating and eye opening. And then I saw the same thing in more biomedical spaces as well, not just public health prevention spaces, but really in therapeutics. And as you know, I eventually discovered a drug that saved my life, a drug called sirolimus, an mTOR inhibitor. And it had been around for decades for organ transplantation. It hadn't been used for Castleman's. But that for me was the ultimate, oh my gosh, this drug was always there and we hadn't figured out how to use it for this other disease. And again, not to blame anyone, but just to say, wait, okay, we didn't used to share outcomes for trials and we didn't figure out how to do that. That's not good, but that's one thing. And we don't collaborate very well. We have drugs that can be used for more diseases, and there's people that could benefit from the drugs we have, and they're dying because we haven't figured out how to work across disease specialties to figure this stuff out. And that for me was been my fire for these last 11 years. How do we unlock the full potential of the drugs that we have? And of course, the first thing to unlock the potential of a drug is to make the right diagnosis. The second thing is, of course, to think about these biomarkers. But the third thing is, how do we make sure all the drugs we have that are approved for one disease are used for all the other diseases they can possibly treat? As I mentioned, that's what my fire's been these last 11 years. In the last few years in particular, we've been utilizing artificial intelligence to make these matches across drugs and diseases and then drive them forward.
In essence, I think you're saying that these bits of knowledge are out there, but they're not connected together in a way that can be useful.
That's right. It's all to this concept of untapped potential. There's these data sets that are out there that could help to inform diseases. And oftentimes they sit in silos within one institution or another, or even within the same institution, like two researchers in the same place, they don't even know about data. So one is the data is untapped. And then the other is that as a result of data having untapped potential, drugs have untapped potential. And what we're doing, I started a nonprofit about 3 years ago called Every Cure, and what we're doing is we're utilizing data. So we use biomedical knowledge graphs that basically bring together the world's knowledge of all drugs and diseases into one two-dimensional map of every drug, disease, gene, protein, and how they're connected. So we're trying to basically leverage the data through biomedical knowledge graphs in order to untap the potential and unlock the potential of our existing drugs. We can use the connections between every drug, disease, gene, and protein and train algorithms on the known treatment relationships to then predict what are other uses for medicine. So can siltuximab, which was made for Castleman's, also be used for GVHD, or could sirolimus for organ transplant protection also be used for Alzheimer's disease? But utilizing the world's knowledge of connections to start to make these predictions, and then us medical scientists can then say, let's look at the things at the very top. What are these AI algorithms saying? Or like, where's there a signal that that drug might treat that disease? And then can we humans dig into it further and see if we can maybe do laboratory studies or maybe do clinical trials, but really to make sure that we can unlock this hidden potential.
The mission of academic medicine, the mission of all academics, has long been to generate and disseminate knowledge. But it seems to me that people have too long defined knowledge in terms of facts or bits of information or these little chunks. But you're talking about connections and actually connecting all these things together. And it feels like universities are not as well organized for working on the connections as they are for generating the nodes.
That's a great way to put it. Yeah, I think you're right. I think that we're very good at generating individual nodes in a graph. Like, this is all the stuff we know, but you're right. The edges that connect them, we're not as good at. And as a result, we're not able to learn from what happens in Castleman's to do something in GVHD, for example, as I mentioned earlier. I think it's a really good point. I think that the other major realization for me that I think is important for all of us in biomedicine to remember is this idea that just because it hasn't been done yet or hasn't been tried yet doesn't mean that it's not going to work. And just because we haven't made a connection to say that GLP-1s could be useful in Parkinson's disease doesn't mean that it's not going to work in Parkinson's disease. And actually, we have early insights to believe that maybe it will. And so I think that it's just this general humility about what we know and recognition that we know a lot of really amazing stuff. We've generated a lot of those nodes, but there's a lot of ignorome in our understanding of things. And if we can have that humility to understand that there's a big ignorome, that I think will help us to look for connections and help us to have an open mind.
And that's a great place to end. David Fajgenbaum, thank you so much. It's been really a privilege to have you on LabMind today.
Oh, thanks so much for having me, Brian. These were awesome questions and a lot of fun. Thank you.
LabMind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Cherie Peterson, with audio engineering by Isaac Acosta-Alvarez. You can also find other LabMind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to LabMind on Apple Podcasts, Spotify, or your other favorite podcast app, and please leave a rating and review in order to help others find the podcast.